Okay, good morning. This is the first lecture for dental public health. And what I'm going to do is I have approximately 8 hours of lecture material, and rather than try to do it in two 4-hour recordings, I'm going to divide this up into 1-hour recording sessions each. I'm going to record them, and I'll label them like lecture 1 with the date, lecture 2 with the date, and that way then you can watch them at your leisure. And I think I probably could get you maybe an hour at a time before you totally lose interest or start to play games on your phone or whatever else you've got there. What we're going to do is with public health, I've got the lecture to finish, and that should be complete, and then we'll have an exam, your exam number 2. I still need to figure out how we're going to do that. We may do it on D2L. Right now I'm thinking in terms of I have Dental Hygiene 4 signed up to D2L, so I would put the exam under the Dental Hygiene 4 heading in D2L. And then you also will need to turn in your school presentations, and I think we can do that back and forth via email. If you guys will work together, get what you think is your final draft of your presentation, email it to me. I'll look at it. If we need to make some significant changes, I can send it back to you. But I need to have that before the deadline in order to be able to kind of make suggestions and send it back to you. In Dental Hygiene 4, you have your PDP and you have your resume that you need to turn in. I have been sending some possible webinars that you guys can watch to earn PDP points. I will look at possibly some webinars that will help you earn some extra points, maybe for public health also. If with these webinars, some of them you'll just get the 5 points for watching. I think some of them I'll give you the option of, if you send me a write-up via email, then I can give you 8 points. If you watch the webinar, you send me a certificate that you attended and a write-up, you can get 8 points for that. I will sometimes today try to work up the sheet where I update all your PDP points, so each of you will know how many points you have at this point in time. Okay, so let's start with our first dental public health lecture. And what we're doing is, remember, we divided this up into, basically this course into 4 categories. We had assessment, planning, implementation, and evaluation. The most probably critical areas are going to be the assessment, and we spent quite a lot of time on that. Planning, the planning we covered when you were actually planning for your school presentations, and the planning focused primarily on lecture planning, developing your objectives, your concepts and your objectives. We also looked at planning at the last face-to-face class session, in which we expanded it out to a broader scope. So we're looking at planning, some of the things we have to think about for planning on large-scale programs, not lesson plans. Implementation, you've done the implementation with your presentation, so that basically is extremely short section. And now we're getting into evaluation. The evaluation is also going to lead us to research and statistics. Program evaluators and researchers use the same terminology. They use the same statistical manipulations, but how they use them, how they can manipulate these things varied, because the focus of each one of these groups, the programmers and the pure researchers, their focus is going to be different. So let's talk about evaluation of public health programs. First thing and foremost is the accountability. You are accountable to consumers, the providers, and all involved agencies that have participated in the budgeting, the planning, the implementation, everything that's involved with a particular program. Whereas on a private practice setting, your accountability is to the patient. It's the provider to the patient. In a lot of cases, it's the provider to the patient and the insurance company. If the insurance, if they have dental insurance, and insurance is going to pay for it. So it's a very small area where you have to look at accountability. On public health programs, there's so many more people involved. And with the accountability, what we're looking at is how effective and how efficient did this program, or was this program, in terms of effectiveness, did it meet its objectives? If you said you were going to reduce the DMFT scores in a particular population by 50%, and you only reduced it by 20%, then, whether or not that program is going to be continued is going to depend upon if you have any critical incidents that occurred, anything that affected the performance of that program. We also look at cost effectiveness in terms of, did you meet your objectives within a reasonable time frame and with a reasonable budget? A classic example would be you're in Florida and you set up a Pitt and Fisher sealant program for kids in Florida. And so in this particular community or region, they set up Pitt and Fisher sealant programs, and they spend 90% of their annual public health budget that's designated for dental. They spend 90% of it on this Pitt and Fisher sealant program. Somebody comes back and looks at this and says, okay, yeah, you have reduced the level of decay. This is a good preventative action. But in doing so, you spent 90 to 95% of your budget. And if you look at the number of individuals who benefit from this, the kids make up only 15% of that population. The majority of the population are retirees. And you spent the bulk of your dental public health budget on 15% of the population. That's not what public health is all about. So in terms of cost effectiveness, they're going to be looking at that also. Modifications to improve. What can you do to improve your program? So with programmers, they are looking at, we're going to talk about product and process evaluation. Programmers are doing process evaluation throughout the entire run of the program because they want to make sure that they are getting the results that they want to get with this target population. And they're going to look at how can we modify it? How can we change it to get better results? So what can be done to improve it? And can it be generalized? In other words, if it works in this particular county, can we use this program or implement this program in a similar county, a county that has a similar population? And can this program be used in that population, and can we expect to obtain the same results with that particular population? So when we talk about accountability, you're looking at a variety of things. Now, let's move to evaluation. There are two types of evaluation. There's product evaluation and there's process evaluation. Product evaluation, another term for that is summative evaluation. It's the end result. You're looking at the end results of a program, and the end results are measured against the program's objectives. How effective was the program in meeting the objectives? How efficient, cost effective, time-wise, number of people that it reached, how efficient is everything that we're looking at. So I think the best way to look at this would be to look at a scenario. In 2010, the following objective was developed. By 2020, the incidence of decay in the permanent teeth of school children aged 6 to 16 in Molarville, Texas will be reduced by 50%. What type of objective is this? Is this going to be a process or a product objective? So if we're looking at this here, this is kind of the end result, right? We don't know how we're going to get to the point where we're going to reduce by 50%. This is our end results. So this is going to be our product objective. Now, how will the program's effectiveness be evaluated in 2020? What are we going to look at to determine, did it meet its objective? Our objective was 50% reduction of decay in permanent teeth. How are we going to determine if we got a 50% reduction of decay in permanent teeth? What are we going to look at with this? And so if you think in terms of, in 2010, we had data. We did an assessment probably in 29 for this particular population, and we got the figures. We took those figures, we sat down, and we planned for something. And so we did our implementation. This thing is going, and we're looking at a 50% reduction. How are we going to determine if we got it? We're going to compare our pre-test to our post-test. are our baseline data. And that baseline data is going to be our mean, our average DMFT score that we got for various age groups when we started in 2010. And then we're going to go back in 2020 and we're going to try to pull samples, which they're not going to be the same kids, but they'll be the same age groupings that we're looking at. And we'll pull samples, and the samples have to be as close as possible to our original samples. So in other words, if we pulled samples from a school that 100% of the kids were on the free lunch and breakfast program in 2010, we're not going to go in 2020 and pull an upper echelon, higher socioeconomic level private school sample from there, because that's not going to be representative. That's not, our sample selection is no good regarding that. So we're going to pull the sample from the same, types of groups or age groups that we're looking at, and we will compare their post DMFT to their pre-test DMFT. Now, if we talk about the type of study that we're looking at here, what are we doing? We are measuring the level of disease here, measuring the level of disease here, and then we're comparing the levels, right? When we talk about descriptive, we talked about prevalence. Analytical, we're looking at what? Causes is what we're looking at for analytical. Relationships between things that could be possible cause or end up with the stats that we get or we find with our descriptive studies. Experimental is we're looking for a cure. We're looking how to prevent something. And remember we talked about experimental, pseudo or quasi-experimental if you're dealing with people. And historical studies are basically what you've done in all your research projects up to this point in time, and that you haven't actually gone out and measured various things. You've gone back to the literature and you've taken the measurements and the stats that other folks have come up with. You gather all that information and then you correlate it and you compare and you come up with your conclusions. So that's historical, things that have already happened. If you're looking at death rates due to tobacco use, that's going to be historical, because you have to look at death rates, people who have already died. So things that have been collected in the past. So if we're talking about comparing the pre-test or our baseline DMFT to our post-test, our 2010 DMFT to our 2020 DMFT, we're looking at what? We're measuring and comparing just levels of disease with doing that. And so that's going to be descriptive type research or descriptive study that we're looking at. Then we also talked about longitudinal and cross-sectional surveys. Just because a study lasts a long time doesn't make it a longitudinal. In other words, it would look like if we started in 2010, we're going to 2020. That's not, that is a long time. It's a 10-year time frame, but that doesn't necessarily make that a longitudinal study. Okay, a longitudinal study means that you are looking at the same sample group over a period of time. So the sample that we pulled from the population in 2010, the various age groupings, 6 to 16, that we looked at in 2010, if we're doing a longitudinal, we're going to follow those same kids until 2020, following that same sample group or those members for a period of time. Now, a longitudinal study can be 2 weeks, 2 months, 2 years, 20 years, but you're following the same group. Whereas a cross-sectional survey, it's going to be one where you actually are looking at the same thing, but you're not measuring the same people is what you're looking at. So in 2010, if we were looking at 6th graders or 6-year-olds in 2010, we come back in 2020, they're not going to be 6 years old anymore. They're going to be 16, and some of them may be included in this same study because they're still within that time frame. Your 6-year-olds would be 10 years later 16-year-olds, so they may end up being part of the post-test. But their post-test, you're looking at 16-year-olds, and you're not looking at 6-year-olds. So we're going to have, we look at 6-year-olds, the people, in the sample who are 6 in 2010, and we look at 6-year-olds in 2020. So it's going to be cross-sectional because it's a long study, but we're looking at 2 different individuals. We're not looking at the same exact 6 to 16-year-olds. So that's kind of like what we have picked up to this point in time, the kind of research and statistics and terminology that I've tried to kind of slide in as it was applicable during our assessment discussion. So let's talk process evaluation now. Process evaluation is also called formative evaluation, and 2 terms there that you could come up with. You're evaluating the various activities that you use to get to the end results, or post-test results. So what we're doing here is we want to check the status and make necessary modifications because we want to prevent the failure of the program. These are usually programmers that use process evaluation, because programmers then, if they're into something and you're partially into a particular study that's going to be running several years, you're not, for this one here, 2010 you start, 2020 you stop, you're not going to get your your assessment data in 2010 and then wait and go back in 2020. If you're a programmer that's interested in really reducing the level of DMFT, decay or caries experience in a population, you want to make sure that this works. So you're going to go back in a couple of years and you're going to pull a smaller sample to see if we're starting to see the results that we want to get from this particular program. Now there's some terminology that you're going to be looking at with this. Record keeping, time sampling, and critical incident are terms that you will see when we talk about process evaluation. And again, the best way to look at this would be the scenario. In 2010, we had a program put into place, okay? Here's our objective again. By 2020, the incidence of decay in permanent teeth of school children aged 6 to 16 in Müllerville, Texas will be reduced by 50%. We've already said that's a product evaluation. So if we come down here, we know we've got to have something. How are we going to get to this? So we've got to have what we call process objective, which with this, we're going to say with the start of the 2010-11 academic year, each school's water source will be fluoridated at the recommended level for the area. And let's say what we've got in Müllerville, Texas, we've got 2 schools. We have an elementary and middle school that are together, and we have a high school. Each one of these 2 schools has its own well water, and that supplies the water to the building. So you can see here, this is one of the processes that we're going to use to get us up here to get that 50% reduction in caries activity. So the area's recommended fluoride level is going to be what? What do we recommend now just kind of across the board? 0.7 parts per million. Prior to about 5 or 6 years ago, the recommended fluoride level was 0.7 to 1.2 parts per million, and it was based on climate, because they thought if you're in a warmer climate, you drink more water, so you need less fluoride in the water. If you're in a colder climate, you drink less water, so let's amp up the fluoride level. Because we have, we're obtaining fluoride from so many sources now, we don't need to adjust, for climate. So they have just said, because we have these other sources, we're talking about, let's just do it across the board, 0.7 parts per million. Now, if we're talking about fluoridating a school's well water, what are we going to look at here? Are we going to leave it at 0.7 parts per million, or do we amp it up a little bit? And so what we do, as we've previously discussed, is you're going to multiply it 4.5 times. What's the recommended level? So for this particular area, 0.7 parts per million is recommended. We up that 4.5 times, and now what they're going to fluoridate the school's water supply, these wells, is going to be 3.15 parts per million. The 3.15 parts per million, if someone was their main water source was fluoridated at that level, from the time they were born, you would see fluorosis. because the maturation or mineralization of the teeth before they erupted into the oral cavity, that systemic fluoride consumption would cause fluorosis. However, with the school's water supply, it's part-time consumption, very part-time consumption. They're only there Monday through Friday from 8 to 3. They're not there on the weekends. They're not there in the summer or Christmas break or spring break. And also during the day, they can't consume water whenever they want to. They make the trips to the, they get water in the cafeteria at lunch, or they have breaks where they can go to the water fountain. So it's limited consumption. So with that limited consumption, that's one of the reasons that they'll up the level of fluoride, is because it is such a limited consumption. And so even drinking school water that's fluoridated to this level is not going to cause any problems, because they start school when they're 5 to 6 years old. At 6 years old, the 6-year molars have already erupted. They didn't get the benefit of this fluoride, this extra fluoride, and the anterior teeth are pretty much mineralized. So you're not going to see any kind of aesthetically displeasing fluorosis. You may see a little bit of fluorosis on the premolars, maybe the second molar, but it's going to be very, very, very mild, because again, we're talking part-time consumption. We're talking those teeth are already, have already started the mineralization process. Now, to do this, there's a tremendous amount of government regulation to fluoridate a school's water supply, or to fluoridate a city's water supply. A lot of regulations that are federal regulations and state regulations, city regulations. And so they're going to have to train somebody to do this. So they had the janitorial supervisor. He was responsible for the mechanisms to fluoridate the wells. So he's going to receive extensive training and certification to do this. So with the start of the 2010 school year, each school's well water is fluoridated 3.15 parts per million. So what happens then is the individuals who put this program, in action, or, got it going, they don't want to wait till 2020 to see if this is going to work or not. So they're going to go back and say, give it a couple of years. And in 2014, the program designers are going to go back to the schools and do what they call a time sampling, which means they will pull a smaller sample than they did for the original assessment statistics, but they'll have to get a representative sample of the various ages, and they will look, and they're expecting some reduction of decay. They're not going to expect a 50% reduction maybe, but they should start to see, DMFT scores go down. Now, we have to remember, DMFT scores for an individual never go down. So what we're doing is, if we have the 6-year-olds in 2010 that we got a DMFT score, and now 4 years later, we've got let's say 10-year-olds. So we'll start 10-year-olds in 2010 were looked at, and now 4 years later we look at 10-year-olds, and those 10-year-olds were 6-year-olds when this whole thing started. So they've had 4 years of this school water fluoridation. So they would expect to see in those 10-year-olds, 9, 10-year-olds, some reduction, or the start of some type of a reduction in DMFT scores. So they get here, and this is called a time sampling. And with this time sampling, they figure out there's no reduction. Nothing has happened. What's going on here? Why are they not getting a reduction? So they look at this, and they discover that the janitorial super died 3 months after the start of the fluoridation program. And his replacement was given an instruction manual to read, and he's been fluoridating the water at the recommended level for the area, which is 0.7 parts per million. So what happens with this, we know it should be 3.15 parts per million for this limited consumption. So this is a critical incident. So we have used time sampling to kind of check as a process evaluation. And in the process of doing that, we discover, okay, there's a problem here. It's a critical incident. So what we're going to do with this is that we're going to make corrections. At this point in time, we're going to, educate this new individual who's doing it, correct that, and start fluoridating the school's water at 3.15 parts per million. this is going to affect the final stats or the final results for this, because you've had 4 years of water fluoridation that has not been at the level that was designated it needed to be. So maybe instead of getting a 50% reduction, you only get a 30% reduction. Okay, you need to record this in your record keeping as a critical incident, because when you have to have accountability to the powers to be, that's something that you are going to have documented and say, we only got this 30% reduction rather than 50 because the critical incident, this is what we discovered. If this had been, the water had been fluoridated at the recommended level, the 3.15 for the full 10 years, we expect we would have had the 50% reduction. What they're probably going to do also when they report this is they'll say, okay, we did not see a significant change maybe in the 10 to 16-year-old group that we expected to see, but because they were not drinking the 3.15 parts per million for the entire time, whereas those that started, say the 6-year-olds that started in 2014 when the water fluoridation level was corrected, then they would have the full benefit on for the rest of the particular program for, you know, how long it runs to 2020, and they would see maybe the 50% reduction. So whenever you're doing something like this, we have to think in terms of, you need the record keeping. You need everything written down so that everybody understands what everybody else is doing. And this is going to be important because, one, we talked about, if we're talking about a public health team, we're not talking about you and your patient. We're talking about maybe a team of, 40 or 50 that are working with a population that consists of 10 or 100,000. So you've got to know, everybody's got to know what's going on. They have to know, to prevent variability. If you're doing examinations, we want to avoid inter and intra-examiner variability. We want that reliability, which then calibration comes in. We have to select our samples that are representative. They have to be valid samples. So there's a lot of things that are going on that you have to have all of this information. Now, let's talk about program evaluation and research. There, a lot of times people will look at this and just kind of consider it the same thing because they're using the same tools. They're using the same terminology. But what they do with the results as they're conducting their research varies. We call program evaluation, or let's call those folks programmers. They do applied research, whereas researchers, pure researchers, do basic or pure research. Again, they both engage in scientific inquiry, which means that's a logical, systematic data collection. They use the same assessment instruments, surveys, questionnaires, indices or indexes. If you're talking dental folks, you're talking dental indexes, or DMFT or bleeding indexes, gingivitis indexes, PSRs, things like that. They collect the data and they analyze it statistically. Means you've got to quantify it and you've got to plug it into a computer. You want reliable and you want valid results in data that you're looking at. We want objective data, not subjective data. And we describe the outcomes in formal reports using the same terminology. Programmers, they want to, they have to justify their accountability because they want to see the continuation of the programs. And in order to, they have to demonstrate that accountability in order to continue funding or continue participation. Researchers also will report and research studies because they want to discover, think of it as the universal truth. They want to say, okay, this is how we did this. It was non-biased, and these are the results that we got. So with these results, we can say this is a universal truth, that if these results apply in this particular area, then they're also going to apply with a population in a different area. So a lot of times people get real confused and frustrated when you're looking at this, because particularly if you kind of have the mindset that I don't like research, I don't like statistics, I don't like anything about that. And so you'll look at this program evaluation and you'll start seeing some of these terms, and automatically you'll just kind of turn off because of that. With applied research, it's a systematic, logical study. Okay, you do an assessment to find the problems, and you facilitate your health improvement for a specific population. Whereas basic research, it also is a systematic, logical study of some variables to obtain an accurate or truth, a universal truth, or basic fundamental that can be generalized. So that, an example would be if you're looking for the etiology of AIDS, and they're looking at a particular group, and they're running this research for this group, then they want to be able to say, okay, the etiology of AIDS in this particular population, this will also be the etiology of AIDS throughout all populations in the United States. Whereas if we're talking programmers, a lot of times programmers then, they're not looking for the cure, they're looking to improve the situation. And if you can generalize whatever they set up to the general population, great, but they're concerned about a particular community usually. So, example, you're going to study AIDS cases in a local gay community in San Francisco to reduce, prevent, and or treat the people of San Francisco. They're going to make decisions concerning actions to be taken for a specific program. San Francisco AIDS patients. They're not there to generalize to all of California or to the entire United States. Okay? They are concerned about their immediate community and doing something about the immediate community. Now, if you can generalize this particular program, if another community can use this program that they set up, great. But their number one concern is not going to be that universal truth that we can apply this program, throughout the rest of the world. Their applied research in terms of looking at their particular problem. They're focusing on program performance and success for what they're doing. They can make value judgments. That means they can use whatever is needed to ensure the success or get the desired results. They use process evaluations, and if the process evaluation turns up that something is not working or they're not getting the results that they hypothesized that they were going to get, then they can make revisions at that point. They're going to change it. They're not going to go and continue to do something that's not effective simply because they had to put it in action and get it started. They're going to swap. If it means that need to increase, say, looking at various medications to treat AIDS, they're going to increase the dosages, they'll change medications, whatever they need to do here, because their concern is to, say, reduce or treat the symptoms of their AIDS patients. Whereas if you've got basic research, and I always think of this like as rat research, because in true basic researchers, the pure science, they're the ones that can use things where they can control, okay? With basic research, they can take a rat and they can have the rat mate the rats, and then they can have babies, and then those babies have babies on down the line, and they can control everything about those rats, and then they can put their whatever research study they're undergoing, they can put that into motion. So say we've got AIDS cases in the local gay community in San Francisco. And what they want to do is they want to be able to say, okay, we can expand this so that if this is the etiology of the AIDS cases in San Francisco, then it would stand to reason, my research shows this is the etiology, this is going to be the same etiology to the AIDS cases in Houston or to New York. Okay, they're not just looking at reducing, preventing, or treating one community. They're looking at generalizing it out. They want to draw conclusions from the sample of the target population and generalize or infer to an even larger group. Basic researchers can't make any value judgments. Okay, they can't modify their research once they put it into motion. And say if they've hypothesized that fluoride is going to reduce Carrie's experience, and they're utilizing fluoride, they're putting it in the water, they're following through, and they're figuring out that okay, there's not any reduction in decay. There's nothing happening here. These basic researchers can't say, well, let's up the level of fluoride in the water. They can't make any changes. They have to follow it through, and then the only place they can give an opinion is going to be the conclusions of their research, where they can, come up with, well, we feel like this wasn't effective. We should have, increased the fluoride level in the water or something like that. Whereas over here for programmers, they're doing these process evals and they're tweaking as they go along, because their concern is to find solutions and facilitate health improvements for a specific group. These guys over here are just trying to come up with a universal truth. Okay, if the apple falls from the tree in California, the apple is going to fall from the tree in New York City also. This one I've tried to change the order of this, so we'll have to go this way. So now let's get into research. Some of the terms. There are 4 basic categories of research. You've got descriptive, analytical, experimental, and historical. Okay, we've already talked about these in terms of when we talked about various studies, kind of information gathering. When we're talking about assessment, we were looking at this type of thing. So let's look at these a little bit. Some of this is going to be a review, some of it will be new. We know that descriptive research, the basic tools or instruments are going to be questionnaire, interview, dental indices or indices. And we know the study designs are going to be either cross-sectional or longitudinal. Cross-sectional meaning that you're looking at a sample at one specific point in time, and then you compare this to a survey of a similar sample at a different point in time. Whereas longitudinal, we're looking at the same sample at 2 or more points in time. Now, you could have a longitudinal study that looks at 2 or more groups. This is still going to be longitudinal even though we're looking at 2 different groups, if we're looking at each group more than one time. And so this is where it comes in that if this is what you're doing, you need to know what kind of statistical manipulations or what kind of stats you're going to run in the computer to give you the results for this type of a comparison. This is why it's critical when you're doing something like this, for programmers, for true researchers, whichever side you're on here, you want to make sure you have a statistician on your team, because a statistician, you can basically say, this is what we're looking at. This is what I'm going to be comparing. And the statistician can tell you, okay, because you're using one group and you're looking at it over a period of time, you could look at a t-test. Or if you're looking at one group and you're looking, or more than one group, you're looking at several groups, several different times, you're comparing more than 2 things, then we need to do an analysis of variance, which is an ANOVA. Now, I'm only going to hit on probably the most used statistical tests that are out there. There's a lot of different ones. I'm trying to pull the ones that you're going to see more often in research articles that you read, and that I'm guesstimating that the National Board will ask you a question. So if I was looking at MSU dental hygiene students and I was going to get their attitude or how their attitudes changed over the course of their education, and I was looking at just MSU students, and say I give them, Group A, I give a pre-test in January of 2012, and then I do a post-test in January of 2014. I'm looking at 2 points in time here. I'm going to do a t-test or two-tailed t-test. So think of T for 2 when you're looking at 2 variables. So I'm looking here to here. Now, what happens most of the time in some type of a research study, you look at more than just one group. So when I was working on my thesis for my master's degree, I was looking at how the attitudes of dental hygiene students, how their attitudes regarding their profession changed as their level of education increased. And I was trying to determine at what point in their education, in their dental hygiene program, did we see the greatest decrease, okay, in their opinions or their attitudes regarding their profession. So I took MSU dental hygiene students and I compared pre-test in January 2012 and then we did a post-test in January 2014. Well, I just didn't look at dental hygiene students. I looked at 5 or 6 schools that we're looking at. And so just for this example, if we look at Baylor dental hygiene students, I'm going to compare Baylor's 2012 results to their 2014 results. But you can see here, I'm looking at 2 things here. I'm looking at 2 things here. If I wanted to compare these 2, I'm looking at 2. I'm looking at 2 here. So when you're comparing 2 groups or 2 variables, so this is 2 groups here, my variables are here. I'm looking at this one and this one, that's 2. This one and this one, that's 2. If I compare here to here, that's just 2, and here to here, it's going to be a t-test or two-tailed t-test. Now, I looked at more than just 2. I looked at 5 or 6 actually. So that gets you to a different statistical analysis. So say I have group A from one school, and I looked at 2012 and the post-test 2014. I looked at group B and I looked at group C. I could do a t-test to look at these 2 things, or these 2 things, or these 2 things. But once I started to compare this with this with this, I can't do a t-test anymore. I have to move to an analysis of variance when you're comparing greater than 2 variables, okay? So greater than here. So an analysis of variance, if I looked at compared these groups, that's more than 2, that's an analysis of variance. Now, in a lot of cases, what I did was actually I looked at September 2013, December 2013, May 2014, October 2014. So looking at this here now, I can't use a t-test for this. I have to use an analysis of variance because I'm looking at more than 2 points or more than 2 variables. And a variable is just whatever it is you're looking at. A variable could be bowling balls. A variable could be incubation periods for a disease or different kinds of diseases. And so here my variable is 2013, September, then December, then May 14, October 14. So when I'm looking here, I've got to use an analysis of variance to look at that data. If I want to compare these here, that's more than 2 variables I'm looking at. I've got to use an analysis of variance there too. So in other words, what they'll ask you is maybe just say in comparing, say, dental hygiene school's national board scores for 2012 and the students in 2014. Which of the following statistical manipulations would you use? Well, we know we're looking at 2 variables, two points here in time, so we could use a t-test. But if they said we're comparing 3 schools, 3 groups of dental hygienists, their national board scores, for Group A, Group B, and Group C, their 2012 national board scores, then we can't use a t-test. We've got to use an analysis of variance. So let's look at analytic research. We haven't really discussed that. We focused primarily on descriptive to this point in time. This is cause. Who's getting the disease? Where and when is the disease occurring? So what we've done is with descriptive, we've measured the levels. We've compared. So we know, okay, they're higher in Lubbock than they are in Wichita Falls. Why is this? Why are we getting these results? That's where you come to analytical research or an analytical study. Again, descriptive measures the level or the extent of the problem. Analytic, you can think of that as real simplistic, is you're looking at the cause. And then experimental, I always think of the cure. So with the analytical research, you're going to have terms like a cohort study, a case control study, and a cross-sectional study. So what you're looking at are some of the terms that will be associated with this. With analytical, you've got a cohort study is one group is followed over a period of time. Okay, so this is also a longitudinal study, right? Where you're looking at one group over a period of time. That's the same sample, the same people. We call that a cohort study. It can be retrospective or prospective. Now, what that means is with this, and you're doing analytical research, retrospective means you're looking back. So basically, you're looking back at things that have already happened. A cohort study where you're following one group over a period of time, that's going to be prospective. That means your cohort is followed forward in time. That say you're starting to watch them in 2010, and you watch the same group all the way to 2020, same sample, same people, then you've got a cohort study, one group, over a period of time. That is also what we call a longitudinal study, and it's prospective in that you're looking forward, you're following them along. Retrospective would mean that you would look back, you would look what has already happened, and you would, more often than not, you would have to go out and you would have to pull your information from records that are already there, that you can pull the results from. Now, a case control study is where you have two groups are compared, probably one with the disease and one without the disease, okay? With this is good for determining your risk factors. And this is going to be retrospective, that you're looking back in time because it's based on record reviews. If you've got a case control study where you've got one with the disease and one without the disease, normally what happens is you could do cohort where you look at the one with the disease and you kind of follow it through, and then you follow one without the disease. But then what you're doing with this case control is you actually are retrospective in that you're looking back at your record reviews, and then you decide from there, okay? And how good this is going to depend upon the accuracy of the records. Okay, you have to be careful with your collection of data that has come from other people because that could give you invalid results. This is why it's so important that you look at the sample selection that was used. You used the validity of the instruments that were used, the reliability. You have to look back at that, and then you have to look at that. If you say, okay, all that meets the criteria for a good study, then the conclusions that they came up with, I can use those conclusions, I can use those results as part of my study that I'm looking at. And then the cross-sectional study is where you look at one group at one point in time, which is what we've been talking about. You look at DMFT levels for 6-year-olds prior to fluoride or water fluoridation implementation, and then 4 years later you look at 6-year-olds that have received the fluoridated water. You try to pull the same sample, but it's not the same members of that sample, so that's going to be cross-sectional. Now, if we talk about experimental research, here we've already touched on this. If we're dealing with human subjects, it's really going to be called pseudo or quasi-experimental. That doesn't mean that it's fake research. It just means that if somebody identifies that they did quasi or pseudo experimental research, it means that they are allowing for, we know we worked on humans, and you try to control for as many variables as possible when you're experimenting or working with humans, but you cannot control everything. You cannot control what they're bringing into the study. You can't change it. So you have to take that into consideration. With experimental research, you're doing prospective research also. That means that you are setting something in motion and you are following it forward in time. And clinical trial is something that you're looking at with experimental research. A lot of times you will actually, if you're testing the effectiveness of a particular problem on disease. In other words, if back in the 50s when they were looking at fluoride, water fluoridation, and reduction of caries activity, they did a clinical trial. In other words, they, would pull and actually conduct that on a group of people where they had fluoridated water and non-fluoridated water, and they worked through that. And this gets us to the experimental research and the scientific method. Normally, the National Board will ask you a question or two regarding the scientific method. There are 6 steps to it, and they're going to want you to know what those 6 steps are, which one comes first, or what happens during each step. First one's going to be the statement of the problem, which we have already talked about this earlier on in the semester when we talked about the statement of the problem and a hypothesis versus a null hypothesis when we were discussing fluoride, water fluoridation. So a statement of the problem was really a question of the unknown. You got a question there. And, does fluoride have an effect on decay? That's something that you're looking at. But some other examples, particularly if we're talking about like fluoride, it would be the relationship between fluoride and dental decay is unknown. So back in the 50s and the 40s when they were looking at this, this wasn't the first research that was ever done regarding fluoridation, water fluoridation, because they first had to figure out or identify that fluoride had an effect, that fluoride was something. They probably started out, they could have said the relationship between calcium and dental decay is unknown. The relationship between magnesium and dental decay is unknown. They were looking at, more than just fluoride. They were looking at a lot of different things, trying to identify what was causing fluorosis. And, looking at, okay, with fluorosis, we have a reduction in the incidence of decay. How is all this working together? You could have something like the relationship between clinical practice 4 requirements and student stress is unknown. Or the relationship between sports drinks and dental demineralization or erosion is unknown. So you have the statement of the problem saying, okay, this is what we're going to be looking at. And then you're going to come up with your best guess. You're going to say either it's a hypothesis, an H1, sometimes called an alternative hypothesis, or the null hypothesis, which is an HO. And you may see those definitions, you may not. So hypothesis is a statement that something has an effect on something else, right? We've already talked about that. So systemic fluoride has an effect on decay. Systemic fluoride reduces dental decay. Diabetes affects the severity of periodontitis. So these are hypotheses that have already been stated for other research things. We know that fluoride has an effect on it. It reduces dental decay. Somebody somewhere years ago when they were studying this was the hypothesis that they set up. Each one of these was set up by multiple teams of researchers looking at the same hypothesis, many more hypotheses regarding diseases and health than just that, we're looking at fluoride or we're looking at these 3 here. Whereas a null hypothesis, you're basically stating that there's no effect on something, okay? So it could be systemic fluoride has no effect on decay, or systemic fluoride does not reduce dental decay, or there is no relationship between diabetes and periodontitis. You can see here how they would take a statement of the problem, and with this one here, you would say the relationship between diabetes and periodontitis is unknown. That would be their statement of the problem. Then they could come down and they could either say diabetes affects the severity of periodontitis, or they may say there is no relationship between diabetes and periodontitis. They could go either or depending upon where their focus is going to lead them. So let's look at some examples here and try not to look at your paper where I've given you the handout that's got everything circled already. Clinic 4 requirements increase student stress. Is this a hypothesis or a null hypothesis? It's going to be a hypothesis. We're saying there's a relationship between student stress and Clinic 4 requirements. There is a relationship between social economic level and oral cancer. Again, are we saying that there is an effect or there's no effect? That's going to be a hypothesis also. How about there's no significant difference between junior and senior stress levels? We're saying what? There's no effect, there's no difference, nothing going on. That's going to be a null. There is no relationship between alcohol consumption and oral cancer. Again, that's going to be a null hypothesis is what we're looking at. So when we look at hypotheses then, hypotheses, we're looking at probability level of the p-value. And the p-value, they'll ask you some questions regarding the p-value and the significance of something. And I will ask you questions on your next test about the p-value or the level of significance for testing the hypothesis or the null hypothesis. The p-value will tell you whether you're going to accept the hypothesis or reject the hypothesis, or whether you're going to accept that there is no relationship, or you're going to reject this and say there is a relationship. I said there wasn't, but there actually is once I plug it all into the computer. So what the probability level does is it sets the level of acceptable chance that the study sample will show a difference between groups, even when there's no real difference, okay? Or that the study sample is not representative. What you're looking at is the level of significance is usually set at 5%, or basically less than 0.05 is what you're looking at. If you've got results that are less than 0.05, that means that there is a statistically significant difference in it. And so less than 5% that a difference was shown when there was really no actual difference, or that the difference occurred by chance. So we're looking at this and we're saying, okay, there is a statistically significant difference or relationship if we've got a p-value that is less than 0.05. If your p-value is greater than 0.05, that's not statistically significant, okay? Now, when we talk about 05, a lot of times you'll see in research that they'll set the probability level at 0.03. That's even better, because what they're saying is that there's less than a 3% chance that the results we got were affected by something else, that the difference just occurred, you know, by chance or something. A lot of times what happens is if they're studying products like various things that are going to be looking at fluoridated toothpaste. Fluoridated toothpaste, they'll do studies on that, and if they get a probability level that is 0.03 or less, that means that there's a less than a 3% chance that this toothpaste actually reduced the level of decay just on accident or by chance. That they're saying there's less than a 3% chance that something outside, some other variable caused these results. But, you know, less than a 3% chance that it's not this, fluoridated toothpaste that did the trick here. Now, confidence interval, you'll see that term also. That corresponds to the p-value. That means if the p-value, probability level, is less than 0.05, there's less than a 5% chance that the observed results were due purely to chance. That means your confidence interval is going to be 95% sure that the results were not due to something outside, some other variable besides what we're looking at. That's your confidence level. Okay, we're almost out of time here for this first hour of lecture, so I'm going to stop here. We will pick this up again in the next hour. Go over this probability level again, and we'll actually look at how this is going to work with our hypothesis and our null hypothesis.